Hello, I'm Kevin Fernando, a GP working near Edinburgh in Scotland and content advisor for Medscape Global and UK. Welcome to our podcast, Medical Mentor, a bite-sized regular chat for all of us working in primary care. Podcasts will cover hot topics, practice pearls and hacks, as well as pitfalls to avoid, helping make our lives a little bit easier in primary care, but ultimately to help improve the lives of our patients. In this podcast, I'm going to talk about the interpretation and management of hypocalcemia, or low calcium levels in primary care. So let's start with some grassroots, simple calcium physiology. Most of the calcium in our bodies is stored in bone. Calcium has a key role in skeletal mineralization. However, in addition to this role, calcium is also involved in many pathways throughout the body, including enzyme pathways, muscle contraction, blood clotting, and maintaining a regular heart rhythm. Hence the wide range of symptoms and signs associated with abnormal calcium levels, which I will cover shortly. A normal calcium range is around 2.15 to 2.60 millimoles per litre, but reference ranges and units will vary globally. We often get corrected calcium levels reported in primary care. What's the relevance of this? Well, in the blood, around 40% of calcium is bound to proteins such as albumin. Abnormal albumin levels can make total calcium levels appear too high or too low. So corrected calcium levels are a better indicator of the amount of calcium that is free in the blood for its physiological functions. So corrected calcium levels are recommended for people with hypoalbuminemia, or low albumin levels. Now, parathormone, or PTH, is the main regulator of calcium homeostasis and is secreted by the parathyroid glands in response to low calcium levels. PTH increases calcium reabsorption in the kidneys and stimulates conversion of vitamin D, which in turn promotes calcium uptake in the bowel. PTH also stimulates osteoclast activity to release calcium from bone. And the overall effect of this is, of course, to increase blood calcium levels. Calcitonin is released by the thyroid C cells in response to increased calcium levels. Calcitonin stimulates osteoblasts to deposit calcium in bone and also inhibits the renal reabsorption of calcium, therefore increasing urinary calcium excretion. Calcitonin also reduces calcium uptake in the bowel. And the overall effect of this is, of course, to reduce blood calcium levels. Now, calcitonin levels are not tests we typically do in primary care. Calcitonin levels are primarily checked to diagnose and monitor medullary thyroid cancer, particularly in those with MEN, multiple endocrine neoplasia type 2, where screening is recommended. So now let's talk about hypocalcemia, or low calcium levels, which is a common finding in primary care. Now, firstly and importantly, mild hypocalcemia, 1.9 to 2.2 millimoles per litre, is often an incidental finding in an asymptomatic individual. Symptoms of hypocalcemia usually develop when corrected calcium levels are less than 1.9 millimoles per litre, but this is also affected by the rate of change in levels. So what are the symptoms of hypocalcemia? Well, some individuals describe mood change or neuropsychiatric symptoms. Muscle cramps or spasm are also common. For example, carpopedal spasm, which are involuntary muscle contractions in the hands and feet. Poisot's sign is involuntary contraction of the muscles in the hand and wrist that occur after compression of the upper arm with a blood pressure cuff, whereas Vostek's sign is ipsilateral twitching of the mouth and periorbital muscles that occur when the facial nerve is tapped around 2 centimeters in front of the ear. Additionally, hypocalcemia is associated with neurological symptoms, for example, tingling and numbness, or seizures in more serious cases. Also, hypocalcemia can cause non-specific symptoms such as brain fog or fatigue. Finally, hypocalcemia can cause cardiovascular symptoms and signs. For example, cardiac arrhythmias and QT prolongation, due to the disruption of electrical signaling in the heart. So what are the common causes of hypocalcemia? Well, one of the most common causes is vitamin D deficiency or osteomalacia, which I will talk about in a future podcast. Alcohol excess, hypomagnesemia or low magnesium levels secondary to, for example, long-term proton pump inhibitor use, or hypoparathyroidism following neck surgery, neck radiotherapy, or secondary to autoimmune disease can also all cause hypocalcemia. Finally, malabsorption, for example, secondary to celiac disease, can also cause hypocalcemia, as can chronic kidney disease, secondary to reduced vitamin D activation, and certain medications, including bisphosphonates or denosumab, can also cause hypocalcemia. So, how do we investigate hypocalcemia? Well, if there is evidence of persistent hypocalcemia less than 2.2 millimoles per liter of any offending drugs, check bloods for full blood count, PTH, urea and electrolytes, liver blood tests, phosphate, vitamin D, and magnesium levels. Now, if magnesium levels are low, they should be treated before any hypocalcemia, as calcium levels will often correct upon magnesium replacement. Individuals found to have an anemia should be investigated for possible malabsorption, and do consider a celiac screen in these individuals. So what do we do with the results? Well, if blood show an elevated alkaline phosphatase alongside elevated PTH levels with low phosphate levels and low vitamin D levels, do consider X-rays and a diagnosis of osteomalacia, and of course correct vitamin D levels as per your usual local guidance. However, if alkaline phosphatase levels are normal with increased PTH and phosphate, then the diagnosis is actually likely pseudo-hypoparathyroidism, which is a genetic resistance to PTH hormone. And finally, if alkaline phosphatase levels are normal with reduced or normal PTH levels and increased phosphate levels, then the diagnosis is likely hypoparathyroidism. So finally, I've produced a Medscape UK primary care hack or clinical aid memoir on interpreting hypercalcemia and hypocalcemia in primary care for all healthcare professionals. I hope you find this resource helpful. So thank you all for listening. I hope you found this podcast helpful. Please do listen to our future Medical Mentor podcast, which will be available on all major platforms. Follow me on X, formerly Twitter, at Dr. Kevin Fernando, or email me on kfernando@webmd.net if you have any questions, comments, or ideas for future podcasts. Thank you again for listening.